Boom. Good afternoon, everybody. Dr. Maheshwari is there. Probably he will be starting. Dr. Shubhlakshmi, have you tested that you are able to share your slides?
I have not tested. I'll just check.
आप एक बार देख लीजिए please. हाँ. So then we will request Dr. Maheshwari to please start the session.
Okay.
Good afternoon, Dr. Maheshwari, sir.
Good afternoon, Dr. Anupam. Very good afternoon.
Good afternoon, sir.
Very good afternoon, madam.
Sir, is it visible?
It is visible.
Very
एक
much,
बार slide
very
show पे
much
भी check
visible.
कर लीजिए please.
Okay, sir.
Can you make it slideshow?
Yes, sir. Yeah, I'm just. Yes,
Now
sir.
it's
Done.
perfect. Perfect.
Okay, sir.
Change करके देख लीजिए.
Ah, yes, sir. It's
हाँ
moving.
बस बढ़िया. Very good. हाँ. Over to Dr. Maheshwari, sir.
Namaskar, everybody. Very good afternoon to each and one and all. I welcome Dr. Anupam Prakash, Course Director, as well as Dr. Shubh Lakshmi. We are in the next session of the classes, and which is today's class is very important. Everybody knows that it's a brainchild of Dr. Kamlesh Tiwari, who is Dean, Indian College of Physician, and Course Director is Dr. Anupam Prakash, a learned researcher as well as academician. Similarly, Dr. Shubhlakshmi today is a faculty who shall be talking about haematemesis and malena. She's also a very senior person and an experienced person. Over to Dr. Shubhlakshmi for her talk today's talk.
Thank you so much, sir. And first of all, I'd like to thank our course director, Dr. Anupam Prakash, sir, and ICP for this opportunity and this very well designed program for the students, graduates, as well as the other faculty members. So, moving on to the topic, upper GI bleed, that is haematemesis and malena, which I will be taking today. So, very important symptom or complaints with which we usually see patients in our wards. So first of all, moving from the definition, GI bleed or gastrointestinal bleeding from a source proximal to the ligaments of trach. This we have learned from anatomy class only. So this is very important. So anything above that is considered as upper GI bleed. A fold of peritoneum over the suspensory muscle of duodenum creates the ligament of Treace. In this picture also we can see the muscle is likewise called the muscle of Treace or musculus uh, suspensorius duodeni. So this was the name given to it, and you can see that this ligament is at duodenojejunal flexure. So anything above that, that means up till duodenum, that is upper GI bleed. So hematemesis, actually it presents as overt GI bleed, can present with vomitus that is bright red in color or coffee ground in color. So our melena, when the patient present to us with a black tarry stool, which is very sticky, so that is melena. Another term, that is hematochezia, which is passes of red or maroon color blood from the rectum. So actually this may be upper GI bleed as well in 10% of cases. Otherwise it is lower GI bleed. And fourth presentation may be occult, where the stool for occult blood test is positive. Otherwise patient is not having overt bleeding. So as I have just told, so melena indicate that blood has been present in the GI tract for more than 10 to 12 hours, and it can extend up to 3 to 5 days. The more proximal the bleeding site, the more likely melena will occur in that patient. Hematochezia usually presents as lower GI bleed, but although UGI lesion can also present with hematochezia, where the blood transit time from the bowel is very much fast. So the history should be directed towards confirming the presence of the bleeding, whether the patient is telling what the patient is telling is as bleed is actually bleeding or something else. So that we have to confirm, estimating its amount and rapidity, identifying the source and potential specific causes of it, and eliciting the presence of serious associated disease that might adversely affect the outcome of the patient. So identifying the probable presence of bleeding by the history, as we have just seen, we have to ask about the history. Also on examination, we can check for the hypovolemia. And if patient is giving any history of syncope, faintness or excessive weakness, then also we have to check for that. And it can be an indirect cause of bleeding in the body. Estimate the amount of rapidity of the bleeding. So here we have to ask about the frequency, about the volume of the stool, if it is black tarry stool, or if the patient is having vomiting of blood or altered color blood in the vomiters, then amount and frequency, again, it is important. So we have to actually inquire about the amount that is easily understood by the patient, so that it is like a cup of blood, it was a cup of blood or a katori of blood, or more than that, or amount is less, like 1 tablespoon. So this is how we have to quantify it according to the patient's language. Symptoms of hypovolemia, that is again syncope, faintness, giddiness, or excessive weakness, or anything else. Ask about the site and potential cause. So site we will be just discussing in the later slides, but yes, the symptoms of peptic ulcer disease, varices, gastritis, esophagitis, these all we have to ask in the history, so that we can come to some differential diagnosis with which what we are dealing with. So these will be the complaints if we are dealing with upper GI bleeding. If we are suspecting lower GI bleed, then again we have to rule out other causes like diverticulitis, any colon cancer, hemorrhoid, inflammatory bowel disease, ischemic colitis. So any complaints pertaining to this. So abdominal complaint, if the patient is having loose motion, excessive blood in the stool, and this is not acute, it is chronic. So this time we are dealing with the case of inflammatory bowel disease. Likewise, if patient is having excessive upper GI complaints like belching, or patient is having dysphagia, not actually, but yes, patient is having difficulty in having food because of early satiety or burning, or patient is having vomiting like of sensation, nausea, vomiting type of thing, then we are dealing with something like peptic ulcer disease or esophagitis or gastritis. So this is how we have to classify it. We have to determine the presence of other situation or comorbidities in the patient, so that we can act accordingly, because patient with comorbidities, the outcome will be not as better as in other cases. So any patient who is having any cardiac condition, any lung pathology, cirrhosis, renal failure, and advanced cases of malignancy, elderly patient, or with clotting disorder, so these are the patient which will require specific attention if they are presenting to us with a GI bleed. Causes, as we have just discussed. So the percentage wise, if we think, non-varicose bleeding causes are peptic ulcer disease, which is most common. That is 30 to 50% of the cases may present with us. Malarivisteria, 15 to 20%. Gastritis and duodenitis, 10 to 15%. This gastritis and peptic ulcer disease, the symptomatology almost are similar in both the conditions. So that we have to differentiate, or we have to confirm it with endoscopy or with any other investigation modalities. Esophagitis in 5 to 10% cases, arteriovenous malformation, tumors, and other conditions. So these are the less common causes. Coming on to the portal hypertensive bleeding, that is varicose bleeding. So here gastroesophageal varices accounts for about 90% of the cases if a patient is presenting with upper GI bleed. Hypertensive portal gastropathy, less than 5%, or isolated gastric varices, less than 5%. So usually gastroesophageal varices are the condition which we usually deal with. So the hypovolemia, what we were talking was, so something it is to deal with. If the blood loss is less than 15% or is about 15%, it is usually tolerated well by the patient, and patient may not have much symptom or may not be very much symptomatic. But as the volume depletion become larger, the constriction of the arterioles, shunting of cardiac output from non-vital areas such as skin, bone, occurs. Tachycardia, decrease in cardiac output, and orthostatic hypotension occurs. Patient may be giddy whenever he or she may present to you. The patient is likely to be thirsty and feel fainted whenever standing. So this orthostatic hypotension complaint should be inquired about whenever we are dealing with a case of GI bleed. If the loss is 40 to 50%, when it increases to 40 to 50%, the ability to compensate is almost lost, and the patient may present to us with shock, impaired blood flow to the vital organ, tissue hypoxemia may be there, and ultimately, if it is not taken care timely, then this massive GI bleed can lead to death. This Glasgow Blatchford score was used where the components included blood urea nitrogen, hemoglobin levels, systolic blood pressure, heart rate, and other markers like malena, syncope, hepatic disease, or cardiac failure. And every component has been given a number. That is the scoring. That is the score which. That is the score. That was the score which was used in this scoring system. So what actually was to be done, or how we can
So the first aspect of voting element is I'll show you a live demo each of the three groups. So the first
may I request all the others to please mute their mics.
Everybody, all attendees, please mute their mics so that learned speaker can continue. I humbly request to please mute your mic. Everybody, please mute your mic.
Thank you, sir. So I'll continue. So this score actually, what was to be done was, if the score what is given for every component is 0 or 1, it is indicative of that the patient falls under low risk category, where the hospital require. Yes, sir.
No, बना के जाती हूँ.
Yeah. Okay. So the hospital require
No, बिल्कुल
need
नहीं.
of the need of the hospitalization.
बना के जाती है, अभी just गई है.
So need of the hospitalization was very less if the score is 0 to 1. And if the score was 6 or more, it was associated with 50% risk of need of any hospitalization or any intervention. So this score was used for stratification actually. But in our clinical setting, these are all conditions which we were just talking about in our clinical history, as well as in the examination part also, we have to take care of these components. So initial evaluation, we have to ask about the history, what we have just discussed. Any medication also we have to ask if the patient is on any medication. That medication can be NSAIDs, steroids, or any other medication, aspirin. So if the patient is taking, we have to ask the history. On examination, hemodynamic stability, or we have to check for the vitals. Per abdomen examination, per rectal examination is also very important in cases of GI bleed. All the other systemic examination we have to do, but this I have mentioned, this is very much specific for GI bleed. Otherwise also we have to check for the other systemic evaluation like respiratory system, cardiovascular system, and CNS as well. Routine investigation in laboratory findings, laboratory investigation, we have to go with the routine investigation, including CBC, LFT, KFT, everything is to be done. Blood typing and cross matching is required if massive loss is there. So we may need to transfuse the patient with blood and blood products. So this is required. And blood urea, serum creatinine, everything is to be done to check for the other organ involvement and status of the patient at present. First, we have to try it. We have to classify the patient according to the need of the treatment. So, and general measures, we have just seen, we have to check for the status of the patient. We have to go with the routine investigation, ECG. We have to check for the urine output. We have to put Ryle's tube, that is nasogastric tube, and we have to check for the output, whether it is blood, it is bile, whatever is coming out. So we have to check for that. We have to supplement with oxygen. If the blood loss is more, if the patient is not conscious or not hemodynamically stable, then we have to supplement with the oxygen. Patient is to be kept nil per oral. Two large bore peripheral IV cannulas are to be put to supplement with the fluid and blood product, whatever is whenever required. Central venous line and rest of the thing can be used as and when required. It is not for all the patients. Fluid resuscitation is first and foremost thing to go. After that, we have to proceed if the patient is not responding after this fluid resuscitation. So rapid bolus infusion of isotonic crystalloids is to be given first, and then we have to check for the response. And then if patient is not resuscitated by that fluid what we have given, then we have to go for the blood transfusion. So we have to check if the patient is severely anemic, then again fluid transfusion should be very much guarded, and we have to go with the transfusion of the blood and blood product. So if the hemoglobin is less than 10 in high risk patient, that includes elderly patients with other comorbidities or coronary artery disease, then we have to transfuse the patient with blood. If the patient is having less than 7 gram of hemoglobin and patient is having low risk, then according to the need, we have to proceed with the blood transfusion. Fresh frozen plasma is required if the patient is having coagulopathy. Thrombocytopenia, that is platelet less than 50,000, or any other platelet dysfunction condition if we are suspecting, then we have to give platelet if required. Otherwise, this if patient is actively bleeding. Otherwise, thrombocytopenia can be secondary to CLD and can be taken care with the required treatment. We have to proceed with the proton pump inhibitors. So these are the opeprazole, pantoprazole, esomeprazole. So commonly used are omeprazole and pantoprazole, which we give in patient with UGI bleed, where the cause is not varicose. So 80 milligram bolus and then 8 milligram per hour infusion is to be given, which and after 72 hours or so, we can shift it to the oral if the condition of the patient permits. This has seen to be reducing the rate of rebleeding. It reduces the hospital stay and reduces the need of the blood transfusion if the bleed is not massive. It also reduces the endoscopic sign of active bleeding and need for endoscopic hemostatic therapy or any other therapy after if we have timely started the treatment. Other modalities like somatostatin and its analog. So again, this is used to be used in varicose bleed. Octreotide, which is given in bolus of 20 to 50 microgram, and continuous infusion of 25 to 50 microgram per hour is to be started. It also reduces the risk of non-varicose causes, but actually is used in varicose bleeding. Now coming to the UGI endoscopy. So it is a diagnostic modality for UGI bleed. Early endoscopy is recommended for identification of the site, but it should only be done if we have therapeutic therapeutic facility available in the center, because just by seeing the site, if we are not providing any other treatment to the patient while doing endoscopy, then it is of no benefit to the patient. So it should be done only if active intervention modalities are available with us. This endoscopy or early endoscopy results in reduction in blood transfusion requirement because we are identifying the site and stopping the bleed as soon as possible if we are able to identify the site and the cause of the bleed. In general, 20 to 30, if 35% of the patient undergoing UGI endoscopy will require a therapeutic endoscopic intervention, and 5 to 10% usually eventually require surgery if the site of bleed is there and it cannot be taken care by UGI endoscopy intervention. So the endoscopic predictor of recurrent ulcer hemorrhage. So here we can see the endoscopic stigmata of recent hemorrhage. So how, if we are performing endoscopy, so if we are able to see any active arterial bleed or not bleeding but visible vessel, dilated vessel, adherent clot, oozing without visible bleed. So if ooze is there, flat spot, that is flat red spot, that is it may be called as sign of hemorrhage but not actively bleeding at that point of time, or clean ulcer base. So these are the conditions which we can see in endoscopy that patient is having or had bleed. And risk of rebleed you can see. So active arterial bleed, if we are able to see, then rebleed, chances of rebleed is obviously very high. And if that flat spot of clean ulcer base is there, then chances of rebleed is very low. What are the modalities which are available with us in endoscopy therapy? So thermal coagulation, which is there. If the bleeding point is not very much specific, it is diffuse. So thermal coagulation is to be given in a specified area. So there we can use this. Injection therapy, that is sclerotherapy, is used, but again risk is there, because if that sclerotherapy is not effective, then we have punctured the vessel or punctured the site, then again bleed can be fatal. Hemostatic clips are there, where we used to clip the bleeding vessel. These are all emergency procedure. Again, there is glue. This is cyanoacrylic glue, which is used as an adhesive for this gastric fundal varices usually, and it's injected into the varices to stop the bleeding. Again, this procedure is very should be very quick and with a trained hand, because if we have injected the needle and we have injected the glue is very much adhesive, very quick in action. And so supposingly if the glue is not reached the site and it has stick, so the we have already punctured the vessel, so it will bleed and we will not be able to stop it. And the last is the combination therapy. So it is individualized according to the need and according to the patient requirement. So we can mix the conditions, like if glue is not if we are not able to stop the bleeding by glue because of any this thing, so then we can proceed with the injection therapy or hemostatic clip if we are able to clip the vessel. Refractory bleed, if we have given treatment and still oozing is there, hemoglobin is not picking up or still it is dropping, so we can plan for repeat endoscopy. If anything is there, then it is okay, we have to treat accordingly. Otherwise, we have to go for angiography or surgery. So angiography, this is the best initial diagnostic and therapeutic procedure. That is endoscopy, we have already seen. But if it is not able to withhold the bleeding, whatever is happening, so we have to proceed with the transcatheter arteriography or surgery. So it is according to the requirement. If the patient is not responding to the endoscopic therapy or whatever therapy we are providing to the patient. So here again, surgery, indication of surgery is again if the patient is not responding, failure to the endoscopic therapy, hemodynamic instability despite resuscitation, recurrent hemorrhage after initial stabilization, shock associated with recurrent hemorrhage, and continuous slow bleed with the slow bleed along with the blood transfusion we are giving. We have provided the patient with endoscopic therapy. So still patient is not responding, then we have to proceed with the surgery. Second look or repeat endoscopy, again I have told if the patient is not responding and if there is recurrent bleed, then to exclude the previous missed lesion or to retreat the bleeding ulcer, we may require to re-look the patient. So this is for the initial approach how we have to go. So if there is acute GI bleed, we have to put a nasogastric tube to look for the color of the blood or whatever is coming out for by that nasogastric tube. Then we have, if it is bile or if it is coffee ground color blood, or if there is no bile or no blood, so we have to categorize accordingly. And then we have to go with the UGI endoscopy. If it is able to locate the site, then well and good. Otherwise, we have to go with the angiography or surgical angiography to look for the site. Or there is a tagged RBC scan. It is again a investigation modality where the radioactive material is used to locate the site of the bleed. If there is bile and no blood is there in aspiration, then we have to check for the other cause like colonoscopy or angiography. We have to go check for. And if it is not suggestive of any site, then again we have to move on with the tagged RBC scan, or we can proceed with the capsule endoscopy if required. Coming to some detail of non-varicose bleed. So peptic ulcer disease we have seen. So about 10 to 15% of the patient with UGI bleed are of peptic ulcer disease. It is a very common, and bleeding develop as a result of acid peptic erosion into the submucosal vessel or penetration into the larger vessel. Duodenal ulcer are more common than gastric ulcer, and gastric ulcer bleeds more commonly. So the most significant hemorrhage occur when duodenal or gastric ulcer penetrate into the branches of gastroduodenal artery or left gastric artery respectively. Here we can see the cause of this ulcer can be H. pylori, which is associated with the bleed. And in patients who are taking ulcerogenic medication, as we have just discussed, like NSAIDs, SSRIs, or aspirin, or any other drug, so we have to stop that drug. We have to take the history and we have to stop that drug, and then we have to recheck for the bleed if it is stopping or not, and we have to start the patient with some alternative drug if it is very much required. Ulcer of more than 2 centimeter in the diameter, and if the ulcer is in the posterior wall of the duodenum, then the risk of rebleed is very much high. Malarious tear, we all know. So it is the submucosal tear that occur near the gastroesophageal junction after a period of intense retching and vomiting. Usually after the alcohol binge, the patient may present with some amount of hematemesis, and the mechanism is forceful contraction of the abdominal wall against an unrelaxed cardia, resulting in mucosal laceration of the proximal cardia as a result of increase in intragastric pressure. For diagnosis, again UGI endoscopy and retroflexion maneuver is used to check for the fundal part of the stomach, so that if that tear is extending in the fundus part also. So most tear occur along the lesser curvature if we retroflex the endoscope and look. Supportive therapy is often all that is necessary, because 90% of the bleeding episode are self-limiting, because it has appeared or occurred after any retching or binge alcohol, or because of increased pressure. Stress gastritis, multiple superficial erosion of the entire stomach, most commonly in the body of the stomach, is there. So it results from the combination of acid and pepsin injury in the context of ischemia from hypoperfusion state. Although NSAIDs produce very similar appearance, but it is because of stress. Stress can be prolonged hospitalization, can be, as we have seen, hypoperfusion state, or in this ventilator dependence if the patient is in the ventilator for a prolonged duration. So stress can be any type of stress. But the bleeding which occurs after stress is also small in amount, and it will respond to PPIs, H2 receptor agonist, and sucralfate. If this treatment doesn't treats the condition, and if still the bleeding is there, then again we have to go with the other modalities which we have just seen, that octreotide vasopressin, or if again required, surgery and angiography and surgery can be considered if required. Esophagitis, it is an inflammation of the esophageal mucosa secondary to repeated exposure of the esophageal mucosa to the acid gastric secretion in gastroesophageal reflux disease. If ulceration occur, it will cause bleeding, and usually chronic blood loss is there because it is slow, and the ulceration will cause bleeding off and on as and when it is exposed to the acid secretion more often. In immunosuppressed patient, infection of the esophagus can be considered, and some other medication uh, can be the cause of this esophagitis. Another lesion, that is Dualfy lesion. It is vascular malformation found primarily along the lesser curvature of the stomach, can also sometimes present with bleeding, and it can be the massive bleed because vessels are involved. So this here in the picture you can see there is a bleed, a site is there where it is malformed, this thing is there, and patient can present with massive bleed in these type of condition. Application of thermal or sclerotherapy is the treatment and is effective in 80 to 100% of the cases. As we can see, the site was flat, and if we will provide with this therapy, the bleeding may stop. If not, then again we have to proceed with the other modalities which are surgical. These are ectasias. Again, this can be seen in the patient, but not of much importance. Yes, malignancy, if any malignancy, gastric or colonic malignancy. So patient may present to us with anemia or occult blood, stool for occult blood positive report. Here we can check for the malignancy. Significant bleeding may occur, especially with ulcerated lesion, that is GIST. This is gastrointestinal stromal tumor. So this type of condition may present to us with chronic small amount of blood loss leading to anemia and stool for occult blood may be positive in these conditions. Diagnosis can be done with endoscopy. Check for the lesion, check for the tumor, check for the growth. And if it is there, then we have to proceed with the surgical procedure. There is a condition known as hemophilia. It is associated with trauma or instrumentation of the biliary tract or any tumor. So it is actually iatrogenic type of condition where patient may present with bleeding along with jaundice, right upper quadrant pain and tenderness. So again, UGI endoscopy may be helpful in diagnosing, and treatment will be obviously surgical in this case. Bleeding related to portal hypertension. So that were the non-varical causes. These are now coming to the varical causes. So bleeding related to portal hypertension is most commonly resulting from the bleeding of the varices. Dilatation of the submucosal vein due to portal hypertension provide a collateral pathway for decompression of the portal system. So distal esophagus is more common than stomach and then rectum. So this can be seen in this order. Bleeding can be, varices can be seen in this order. Developing 30% of the patient with cirrhosis and portal hypertension, and bleeding occur in 30% of the patient with varices. Compared to non-varical bleed, it's associated with higher risk of rebleed, transfusion, hospital stay, and mortality, because whenever this varical bleed occur, it is massive in amount. This we can see very much dilated varices. It is an endoscopic picture. So for management, after the history, we have diagnosed it to be a varical bleed, or a patient is a case of CLD, already had an episode of bleed and this time again presenting with a UGI bleed. Then we have to follow ABC, resuscitate the patient, start with vasopressor or octreotide infusion. Varical bleed, once confirmed, we have to go with the endoscopic ligation, band ligation, that is EVL, or sclerotherapy. Band ligation is preferred because it is relatively safer, and sclerotherapy, as I told, once the needle is injected and if the drug is not applied or not, then it can be like patient may present to you with excessive bleed. The on table bleed can be more. Once the bleeding is stopped, then it is okay. If it is not stopped, then we have to continue the treatment. With vasopressor, octreotide, and repeat endoscopic banding every 10 to 14 days until eliminated. So actually we don't go with the endoscopic banding so repeatedly, because endoscopic banding, yeah, post banding ulcer formation is very common. That will again lead to stricture formation in the low endoscopic gastroendoscopic esophageal junction. So we will have to wait for at least 2 to 3 weeks, and then repeat endoscopy is to be done. And then if required, again we can go for the bending. At one go, we usually go with EVL bending, or we apply band of not more than 6, because it will again, stretching of the mucosa will be there and chances of rebleed is more. So ideally we can proceed with 3 to 4 bands at a time, and that too also in a circular manner, so that the ulcer formation is not leading to a stricture. Dosage wise, if terlipressin is started, then the loading dose is 2 milligram IV stat, and then continuous dose for 5 days, that is 1 milligram IV every 6 hourly. Somatostatin, if given, it is 250 microgram IV stat, and then 250 microgram per hour it is to be given for next 5 days. If we are giving octreotide, then 50 microgram IV stat, and then 25 microgram per hour is to be given for the next 5 days. So to summarize, we can see if ulcer is present in endoscopic diagnosis. If we have done UGI endoscopy and we are able to see the ulcer, then we have to check for the active bleeding or adherent clot or flat pigmented spot, or the clear base of ulcer is there. And then we have to provide the therapy accordingly. So medical therapy for active bleeding, along with the endoscopic therapy, we have to provide with the PPI therapy in all the conditions. Diet, we have to ask the patient to take liquid diet, preferably after initial few days, and then can be regulated according to the need or the condition of the patient. Patient should be or can be hospitalized for 3 to 5 days according to the complaints or symptoms of the patient, and should be discharged once the bleeding is stopped, and after that at least 1 or 2 days of hospitalization should be there. If we are able to see Mallory-Weiss tear, then we have to check for the bleeding is there or not there. If bleeding is there, then we have to go with the endoscopic therapy. Antiemetic and symptomatic treatment is to be given, and patient should be discharged only once the bleeding is stopped, and patient is stable of another 1 to 2 days. If varicose bleed is there in endoscopy, then endoscopic EVL band ligation is to be done along with the vasoactive drugs like octreotide is to be given. Clear fluid or liquid diet is to be advised, and hospitalization should be slightly prolonged, as we have just seen. Esophageal varicose bleed is massive many times, which can be fatal if we have not taken care of properly. If the erosions are there in endoscopic UGI endoscopy, then we have to go with PPI and regular uh, bland diet. So non-spicy diet is to be advised, and with the advice of other dietary modification, patient can be sent back after the bleed has been stopped or there is no active bleed. So to conclude, early recognition of the actual bleeding site, or is the patient is having bleed, or he or she is confusing it with epistaxis swallowed in the and again vomiting it as blood, or something else is there. So we have to check that, identify the site of the bleed with the help of diagnostic procedures like endoscopy. Patient is bleeding, so we have to stabilize the patient, and then we have to check what modalities we can offer to that patient, and then along with the general measures, specific treatment if available for that condition, that is to be given to that patient. So thank you very much for your patient listening.
Well, if there are any queries, you can write down on the chat box or ask Dr. Shubh Lakshmi.
So there is a question, can lower GI bleed can present with malena? It is less likely. If the transit time is less, then only it will present, otherwise not. So malena is usually upper GI bleed, and lower GI bleed usually not present with malena. Nasogastric tube for minor bleed only. So nasogastric tube is actually for if actively bleeding. So we have to decompress. And secondly, if the history of bleed is there, like patient present to us is us with history of bleed. Patient is having bleeding and 2 days before, and now because of apprehension, patient present to us. So we have to check whether the patient is having active bleed or it is altered color blood. That is, blood was there and now it is not there. So for that, actually, it is to be checked.
There is a question on hiatus hernia can cause bleeding.
Yes, hiatus hernia, if erosion is there, then only it will cause bleeding. As we have seen gastroesophageal reflux disease. So because of that reflux only, it may cause bleeding, otherwise not. And it will be very mild.
Well, I agree with Dr. Shubhlakshmi, but these are very important questions. Hiatus hernia per se will not cause bleeding, but at times what happens, patients have long-standing hiatus hernia, and if they start losing weight or develop constitutional symptoms, at times there is a malignancy hidden there, which may be the cause of bleeding, and then at times it is missed also because it is part and parcel of the hiatus hernia. So it is very important that if you have bleeding with hiatus hernia, always think of alternative causes.
Yes, sir, very correctly
Octreotide
said.
can be used for preventive.
Because of that fold also, many times it is missed. The lesion is behind that fold. Lesion can be definitely missed in endoscopic procedure also.
Octreotide can be used for preventive measures. we don't use octreotide for prevention, but yes, if the patient is bleeding, you start on octreotide, then you continue for secondary prophylaxis for at least 24 hours. Dr. Shubhlakshmi, your comments?
Yes, sir, definitely. We have to give only if patient is bleeding, and then we have to continue it.
Hiatus
Hiatus
hernia with
hernia,
normal mucosa will not bleed. That is what Dr. Shubhlakshmi
yes,
said. You can have erosions and other possibilities which you can have in normal intestines also, upper GI mucosa. Then only it will bleed. Hiatus hernia will not bleed otherwise. Well, the participants are supposed to send the topics that they want us to address. We have our list, so we will be sharing that list, but I am awaiting some topics from you so that we can finalize the program. So you can write down on the group. We have the group, the WhatsApp group, and you can write down, or you can write down alternatively to Dr. Kamlesh Tiwari also. And I think it has been an interesting session and a very enlightening one. Quite a lot of facts that Dr. Shubhlakshmi has shared for everybody. Thank you, Dr. Shubhlakshmi, and thank you all participants. I think Dr. Sanjeev Maheshwari is not there now. So we thank him also for starting the program today, and thanks to Dr. Kamlesh Tiwari, Dean ICP, for giving us an opportunity to conduct these sessions. Well, thank you so much. We will call it a day today. Thank you, Dr. Shubhlakshmi, and everybody else who has been here. Thank you.
thank you, everyone. Thank you, sir.